Coordinator for the Developmental Disabilities Administration. We welcome you to the Friday series of DDA updates. Our presenters for today include Bernie Simons, the Deputy Secretary for DDA, and we also have Valerie Roddy, Director of Fiscal and Operations, Robert White, Director of Fiscal and Operations, Rhonda Workman, Director of Federal Programs, Nick Burton, CMRO Director, Regional Director, Tanya Ferguson, DDA's Chief of Staff, Dr. Kenny Fader, Epidemic Intelligence Service Officer, Centers for Disease Control and Prevention, and Jamie Rubin, and she's MSRN, Infection Prevention and Control Senior Specialist from the Office of Antibiotic Resistance and Healthcare Associated Infection Response, Infectious Disease Epidemiology and Outbreak Response Bureau. Before we begin, I'd like to go over a few things about the webinar. All participants are in listen-only mode. There are two options to hear the webinar, by computer and by phone. And if you look to the panel on your right, there's a section, an audio section, and you can click on computer or phone to switch. There is a handout for the webinar, and you can find it in the handout section in the panel to your right, and they can also be emailed upon request. We will be recording the webinar and posting the YouTube link on the DDA website. Questions can be typed in the question or chat box in the webinar panel, and if we have time, we'll get to those at the end of the presentation. So now I'd like to introduce Deputy Secretary Simons. Good afternoon.
Good afternoon. Hopefully everybody can hear me okay. I'd like to welcome everybody. It's amazing because we've been doing these webinars every other week, and last week DDA had their budget presentation, so it's actually been a month since we've had the opportunity to engage with everyone. I want to welcome the DDA staff who are presenting, and also thank Dr. Fetter and Jamie Rubin for being with us today. As we know, this month marks the one-year anniversary of the cases that were confirmed in the state, and you may have seen this, that the governor did a proclamation about 14 days ago on March 5th, remembering all of those who have lost their lives to COVID-19. It's also a year since DDA has been teleworking, and that a lot of the individuals and providers had closed their agencies to congregate settings, and started to get creative and figure out how services were going to be and supports provided to individuals in a different setting. So I know that this has been a big lift, and I want to thank you for your wonderful effort and your commitment. Today, obviously, we're going to hear some critical things from all of our staff. Dr. Fetter will be giving us an update, as well as Jamie Rubin, and then you will hear some of the areas that we've been working on with the providers in the regions on vaccinations from Nick and other areas. So with that, we can go to the next slide, please. So again, I appreciate everybody for being here, and again, the questions, the feedback, the recommendations have just been so rich with thought and making sure that we are all staying well informed, and what areas that you want to hear more about. And I want to thank everybody who's providing supports, and to people with the IDD and their families, the microboards, people who are self-directing, etc. And please continue, even though we hear from the governor that we're getting more and more vaccines coming in, and more people we see when they report out have been vaccinated, but we still need to continue, as you saw his order the other day, practice social distancing and wearing your mask, etc., etc. But I do encourage everybody to get vaccinated. We know that we've had some pretty good success. We'll hear about that from Chief of Staff Tanya Ferguson, I believe, later on in this. And again, I want to thank everybody for your continued support and everything that you do. Next slide, please. Okay. And so March as you know, is Developmental Disabilities Awareness Month. It started in 1987. And it's a time when we especially want to celebrate all of the accomplishments and achievements of many of our friends with intellectual and developmental disabilities, while keeping in mind the important work that still needs to be done. We know that we started in 2014 with the community settings rule, etc. Obviously, we know that people want jobs. We see that when people participate in their person-centered plan. We know that Maryland is an employment first state, etc. And again, we need to move forward with making sure people's dreams and aspirations become reality. And so DD Awareness Month 2021 is a great way. You can see the link on there, and I would encourage people to take a look at that and look at our posts that are on our Facebook, etc. Next slide, please. You'll see that here's the governor's proclamation that he did for March 2021 as DD Developmental Disabilities Awareness Month. I'm not going to read the slide to you. You can see that on the right-hand side, and you can see that the highlights and the bullets there that he's done, and he ends it with, Lawrence A. Hogan, Governor, proclaim DD Awareness Month, etc. We appreciate all the support we get from the governor and from his administration. So again, I'm not going to read this. You should be able to see this in the a little bit better than probably what's on the screen when you can download this. So next slide, please. So last week, Governor Hogan announced, I should say this week, he announced that the COVID-19 ICU beds have dropped below 200 for the first time since last November. And then earlier in this week, he announced the steps to ease a lot of COVID-19 mitigation measures while keeping, as I said earlier, your mask on, distancing, etc. You can see that when you click on this, that it'll talk about capacity limits and for a dining, retail business, religious facilities, etc., and that they can go up to 50%, and the issues around quarantine requirements lifted on out-of-state travel, etc. And as the governor did announce the other day, the Western Maryland vaccination site in Hagerstown should be opening on Thursday, the 25th. And so obviously that's great. We've got the vaccination sites in Baltimore. We've had one down at Prince George's County at Six Flags, the one open in Salisbury. So now we've got everything, and we think that this is absolutely wonderful, especially with what the governor's talked about in about 2 weeks from now, that we should see a substantial increase in the amount of vaccinations coming into the state. Next slide, please. So Governor Hogan also announced that licensing and permitting authorized a suspension of licensing and permitting expiring with the sunset of June 30, 2021. And again, there's a link here for you to go in and take a look at the Maryland Department of Health directives that relate to this, etc. And I'm not going to read them. I think that I want to get to Dr. Feder and Jamie and the other presenters. And again, it's available through the links. And again, as Donna said, this is recorded, and basically you can download and get to the links. Next slide, please. So just a reminder that we're moving from phase 1C to phase 2, as the governor said the other day. There's also the pre-registration for mass vaccination sites that's now open for people who are 60 and older. And you can see that the website is there on the bottom on COVID Maryland. And so obviously phase 1A, 1B, 1C is still going to be a priority before phase 2 opens. And that's the way the governor has presented this, that, even though it's open to more of the population, those priority folks are still there and still should be considered a priority in getting their vaccine. Next slide, please. So during his press conference yesterday, the governor shared his, again, the eligibility and the timelines for people who are 16 and older and what that looks like. And you can, again, go back and start taking a look at this with which groups will be starting when, like on March 23rd, will make phase 2 eligible, et cetera. And then on all Maryland is 16 and older, will be eligible by April, which is down in phase 3. You'll see. So, and obviously pre-registration would be a good way to make sure that you get an appointment and get registered. And don't forget to continue to work with the DDA regions as well as your local health departments for hosting clinics, et cetera. And again, Tanya Ferguson will talk about that in a little bit. Next slide. So there has been some specific areas. And you know that the Prince George's did a pilot to assist with people that they provide supports to, and other people within Prince George's County. And I believe they also had people from Montgomery County, and it was a partnership with Giant Pharmacy that started in February, and it continues to move on. And so I want to thank the Prince George's for extending it to Montgomery County, not just doing their own county. I think that was really good. And I want to especially note Rob Malone, the executive director, for his leadership and everything he did around moving this pilot forward. Next slide. So we continue to work with the Department of Public Health Services within us in Maryland Department of Health. We also continue to work with Maryland Department of Disabilities, Secretary Beatty, et cetera. And we know that people who only attend day programs or personal supports have not had the opportunity to sign up for vaccines, and we really appreciate again them being able to sign up, but also the providers who have reached out to people who are in self-direction, et cetera, and not just looked at the people who are within the purview of their agency, but other folks, and extended an opportunity for people to be vaccinated. Next slide. Nick, you're up.
All right, thank you. So as Bernie had kind of stated, there's a lot of work happening within the regions in regards to working with our providers, working with the counties, and working with the CCSs and individuals and families to get people vaccinated. And I just kind of wanted to highlight some of the work that we've recently been doing with 4 agencies at this point: Itinerus, Hartford Center, Abilities Network, and the League, through a collaboration with Rite Aid and MDH to get roughly 1,200 people signed up for vaccines within the central region. It's been an amazing effort on the agency's part, on the CCSs that we're collaborating with. We're working on setting up a couple more clinics in this fashion. So I think I'm just so happy about the agencies that have reached out, scheduled, put these on. I know that there's been a couple other agencies within the region who've held mass clinics, and many of you have held the mini clinics with the partnership program, and it is a massive undertaking. So kudos. You guys are doing great things. The hope that I'm hearing in people's voices after these clinics is so heartwarming. So thank you to everyone for making these partnerships happen. Next slide. You may have seen on our Facebook page that we sent out an IDD vaccine interest form specific to Baltimore City Health Department that is looking at setting up a clinic specific for the IDD community. There isn't a final date set, but once we have that date set and they're ready to roll with that, we'll make sure we communicate that. But you can go right now, fill out the vaccine interest form, particularly if you're in Baltimore City. We've also been working with the other counties within the region to make sure that they are capturing the residential group homes who have yet to get fully vaccinated. And like I said, we continue to work in collaboration with the CCSs and the agencies to get some of these larger vaccine clinics set up. So I'm proud of the work that's happening in the central region. Next slide. And I think it's Valerie.
Okay, sorry about that. Had some technical problems. There has come to our attention, as the slide knows, that there are some participants who were previously approved or utilized personal supports and supported living COVID hours via Appendix K, and which are not accommodated in LTSS Maryland in the person-centered plan. Even though these have been transitioned to the EVV system and being paid through LTSS. So due to the extension of the COVID-19 federal state of emergency through to the end of December, DDA is looking at how to extend these hours through to and beyond March 13th, 2021, so that they are available. Next slide. So to ensure that we've had a consistent and efficient approach, to this issue, we are outlining a process to capture missed previously authorized and utilized Appendix K COVID-19 hours in LTS Maryland, while also making sure that providers are paid for the services that they have provided during the transition between PCIs to LTSS. We are also extending the Appendix K COVID-19 personal supports and supported living hours beyond March 13th, 2021, as we indicated. And for additional information, we would suggest that you refer to the DDA Appendix K number 12 memo, COVID-19 related personal supports and supported living hours. Next slide. Bernie?
Yeah, I was trying to get off mute, sorry. So this is basically the updates that we give about where we are. And before I start reporting on these services, I want to say thank you. And, to all of our providers, leadership for hosting the clinics that we talked about earlier, and the number of people who have been vaccinated and people who have been volunteering, et cetera. So I really applaud all of the continued work you've done, and I think it's absolutely wonderful in hosting clinics and assisting people. So having said that, let me just go over some of the numbers that we do. So as of yesterday, March 18th, Central Region had 850 confirmed cases and had 1,200 cases that were negative, and has 53 people who have passed. East Region has 150 positive, 412 negative, and have 6 people who have passed away. South Region has 618 positive cases, 229 negative, and 25 people who have passed away. And the West Region has 361 confirmed cases, 400 negative, and have 17 people who have passed away. With respect to staff, South region 413 positive and 5 staff have passed away. West region 200 positive and 2 people have passed away. East region 218 positive and 1 person passed away. And in the Central region 662 people have tested positive and 2 people have passed away. And we keep all those people who have passed away in our thoughts. So the next slide is the pie chart that illustrates the 17,764, and we're about at 10% now that have tested positive, with about 2,080. And you can see the chart on the right is the breakdown that shows the number of positives that we have by a region. And obviously this is showing the increases that we have had. And it looks like, if you look at the bottom of the chart on the right-hand side, there's an increase of 0 in East and, only 2 in West, and even in Central, the numbers are down with the numbers of increases from what we've seen in the past. So, again, I think everybody's doing a good job with, precautions, et cetera. Next slide. So the chart, obviously, in the left shows the month that we've as I mentioned when we started, of February 18th to March 18th, yesterday, and we've had 7 people pass away in a month. It's probably the lowest that we've had. I don't know. I have to go back and have double check the figures, but in a month, only losing 7 people, I think, shows that the hard work, and unfortunately, losing anyone is difficult, and we want to console their families and staff and providers, et cetera, who have had relationships with everybody. The pie chart on the right shows that 101 people have passed away since the last time we were here. I think it was in the 90s. And next slide, please. So, and this slide shows the people who are self-directing and where they are. The number of people who have tested positive and the number of deaths. Next slide, please. So we started and sent out some requests to the providers. And I'm going to ask the providers to please respond. As you can see on the slide, it shows that, and we started this on February 19th, by the way, that we had sent this out. And you can see of the 218 that we sent out, 129 providers responded, and 89 providers we have not heard back from. We really would appreciate people giving this information back to us so we can see how well our whole DDA family is doing as far as vaccinations and moving forward. So, again, I ask you to respond and please work with your regional directors on this so that we can get a better picture of where we are with getting vaccinations. It'll also help us and with Chief of Staff Tanya Ferguson and Adrian Holloman, our Director of Nurses, are working with the regions and with the providers to get additional clinics and identify areas where we think that there needs to be additional clinics, et cetera. Next slide, please. So again, we've had 9,258, people who've reported. And that's why I'm asking the rest of the agencies to please report where you are, because, excuse me, we have more people than that enrolled in our waiver. So we need to try and close that gap. So we get a better sense of, I mean, even if you haven't had anybody vaccinated, we want to know that also, so we know that how this is moving forward. And again, we know that we've got more than 9,200 people in there. I think it's great that we've got 74% vaccinated so far, and that we are, excuse me, doing well with that. But again, and there's another point. I mean, we need to take a look at the bottom bullet with the 87 clinics that have been provided, and 9 more coming up. Next slide, please. So I think it's great that we start taking a look at it and say, you know, this is really good. We've got people who are in supports. We've got family, we've got administrative staff, direct care, people who are self-directing. So I encourage everybody to still keep going and taking a look at where we are with moving forward with vaccinations. And with that, I'll turn this over to Dr. Feder. Thank you.
Thank you, Deputy Director Simons, and thank you to everybody who's joining today. And just to start off by echoing, as always, what Deputy Director Simons says, how grateful we are for everything that everyone that you are doing, that your colleagues are doing, that your clients and their families are doing to keep your clients safe during this unbelievably difficult time. What I'm going to be talking about today are oh my, I'm looking at the title of that slide and I'm wondering if I sent the correct slides. But what I'm going to be talking about today is actually good things. So we get questions again and again. You know, our residents are vaccinated now, our staff are vaccinated now. What can they do? So CDC has put out updated guidance on this subject, and what I'm going to do is walk through the changes to guidance that have been made now that vaccination is much more widespread. Slide, please. Slide, please. Thank you. Okay, so the key points I'm going to talk about today. So COVID-19 vaccination. So now that vaccination is widespread, and in particular now that many of your residents are vaccinated, it is safer for those residents to resume some important activities. And so the most important changes that I'm going to talk about today are expanded opportunities for visitation and reduced quarantine requirements for fully vaccinated staff following exposure to COVID-19. And then I also want to touch on a few things that are not changing, which are their continued recommendation to use face coverings and personal protective equipment, and continued quarantine of homes following cases of COVID-19 in staff and residents. And after I speak, my colleague Jamie is going to do a refresher about how to use personal protective equipment, just because we know that guidance is always changing, and so we wanted to follow up with this new vaccination guidelines with just a review of best practices for personal protective equipment that you can share with your staff. Okay, slide please. Okay, so just a quick reminder, COVID-19 vaccines in the United States. There are currently 3 emergency authorized COVID-19 vaccines in the United States that are available to the public. There's the Pfizer vaccine series, which is a 2-dose series, which people get 3 weeks apart. There's the Moderna vaccine, which is also a 2-dose series, which people get 4 weeks apart. And just a few weeks ago, Johnson & Johnson's vaccine was emergency authorized. So there's now a 3rd vaccine available. And a nice feature of this vaccine is that it only requires 1 dose. So all 3 vaccines are effective at preventing hospitalization and death from COVID-19. All 3 are effective at preventing symptoms of COVID-19, and all are most likely effective at reducing transmission of COVID-19. So in this presentation, what I'll be talking about is what people can do once they're fully vaccinated. And by fully vaccinated, what I mean is they're now 2 weeks have passed since receiving all required doses of their vaccine series. In other words, if you're getting the Pfizer series, that would be 2 weeks past your 2nd dose. If you're getting the Moderna series, that would be 2 weeks past your 2nd dose. And if you're getting the Johnson & Johnson vaccine, that would be 2 weeks past your 1st dose, because that vaccine only requires 1 dose. So this is about what people can do after they are fully vaccinated, 2 weeks past the final required dose. Slide, please. So just a quick, we can never say this enough. How do we know COVID-19 vaccines are safe and effective? Well, they've already been evaluated in tens of thousands of people in clinical trials, and millions of people in the United States have already received these vaccines, and they're undergoing unbelievably intensive safety monitoring to make sure that these vaccines are safe. So we know these vaccines are safe and effective, and we strongly recommend that anybody who is eligible sign up to receive one. Slide, please. Okay, back to, thank you. Okay, so back to the guidance. So we're going to talk about what the current guidance is, what's changing, and what's not changing. First, with this respect to quarantine. Right now, we recommend that when a resident or a staff of a group home serving a person with developmental disabilities test positive for COVID-19, excuse me, let me start over. Right now, we recommend that when a resident or staff of a group home is exposed to someone with COVID-19, is exposed, in other words, they have close contact with somebody with COVID-19, they must quarantine and they must be tested for COVID-19. And in addition, we put in place heightened restrictions in preparation for the holidays, recommending that if residents leave the home and visit their families or receive medical care in the hospital, they quarantine and be tested when they return to the home. So in other words, we recommend testing following a direct exposure to COVID-19, and we recommend a quarantine for residents just if they go home and visit their families, because we think that's dangerous. So what's new? So two big changes. First, if your staff are fully vaccinated and they're exposed to someone with COVID-19, they do not need to quarantine. If your staff are fully vaccinated and they're exposed to someone with COVID-19, they do not need to quarantine. But they should still be tested. They should still be tested for COVID-19, and this is going to be a theme throughout. We are not changing any of our testing recommendations. Even if we're lifting restrictions, testing is still an essential tool for controlling the spread of the virus. So, okay, so fully vaccinated staff who are exposed to someone with COVID-19 don't need to quarantine, but they should still be tested. And obviously, if they test positive, then they need to go into isolation. Now, fully vaccinated residents, so this is probably the most important change, who visit family, who receive medical care, they should be tested for COVID-19 when they come home, but they can leave quarantine as soon as they test negative. In other words, if your residents leave your home, they go and they visit their family or their friends or their loved ones somewhere else, okay, outside of their home, they should get tested right before they come back or soon after they come back, but they don't need to do a quarantine just because they left the home and visited somebody else if they are fully vaccinated. So what's not changing? So there's no change in recommendations for residents and staff who are not fully vaccinated. In other words, for people who haven't actually received the vaccine, they aren't offered any protection by the vaccine, and so we still expect them to quarantine if they're exposed. And for residents, we're still asking that they quarantine if they visit their families. In other words, if your residents are not vaccinated, they go home, they either have to go to the hospital for some reason or they go visit their families. When they come back to the group home, they should do a quarantine because they're not vaccinated. So leaving the home has much more danger. And if they are exposed to COVID-19, group home residents still, so this is different from staff. There's still a higher standard for residents of group homes than there is for staff. If group home residents are exposed to COVID-19, either by a staff person or somewhere else, even if they're vaccinated, we do still ask that they quarantine. So why is this? This is based on the CDC's guidance, and everything that I'm saying is based on the CDC's guidance for healthcare settings. And there's a link to that at this end of this presentation. And the CDC has established stricter standards for controlling the spread of COVID-19 for people who live in healthcare settings. And in that group, we are including residents of group homes for adults with disabilities. And so because your residents are both at higher risk for severe outcomes and because they could easily spread it to the people who they live with, we are still asking that vaccinated residents of group homes for people with disabilities complete a 2-week quarantine if they are directly exposed to somebody with COVID-19. Slide, please. Okay, visiting family. So some of this is just a repeat of what I just said. So what is our current guidance? So right now we permit residents to leave the home, visit their family. so long as those families don't have COVID-19 or they're not ordered to quarantine because of exposure to COVID-19. But we say when residents come back to the group home, they should be tested and they should quarantine for 2 weeks. So what's new? Now, when a fully vaccinated resident visits their family, they should be tested within 48 hours of returning to the group home or immediately after returning to the group home. And they should quarantine until they get a negative test result. But as soon as they get that negative test result, they're good to go. In other words, we're no longer recommending that 2-week quarantine just because you visited your family. You can visit your family, you come back to the group home, get tested. As soon as you get that negative test result, you're good to go. So hopefully this will make it much easier for residents to leave the home, visit their families. So what stays the same? Well, there's no change in our recommendations for residents and staff who are not fully vaccinated. There's no change in our recommendation for residents and staff who are not fully vaccinated. For those folks, if they visit their families, we do still recommend they do a full 2-week quarantine when they come back to their group. And I just want to highlight some best practices that we hope you will emphasize to your clients and their families when they go home and visit their loved ones. So first, they should practice social distancing from anyone who's not in the household that they're visiting. So, they may visit their families, but if they leave that household with their families, they should still be practicing social distancing. Second, they should wear a face covering if they can tolerate a face covering. And third, and this is very important, they should continue to avoid crowds, poorly ventilated spaces, and places where others do not wear face coverings, like restaurants. So if you go home and visit your family, you can go home and visit your family, but then we would recommend that your family not then go with you to anywhere that's a crowd, a poorly ventilated space, or a place where people are not wearing face coverings, such as restaurants. In other words, we want, group home residents can visit their families, but we don't want that, using that as a chance to engage in these much higher risk activities than visiting them. So those are some recommendations you can provide to families. Slide, please. Okay, receiving visitors, and this is actually probably the most important change. So right now, we do not permit indoor visitation in group homes, and we only permit socially distanced outdoor visitation. That recommendation is changing. With precautions, we think it's now safe for indoor and outdoor visitation to be permitted in group homes. In other words, your residents can now have visitors in their group homes, both indoor and outdoor visitation, with precautions, if these precautions are followed. What's the same? Well, still visitation is not permitted during a COVID-19 outbreak. So if somebody in your home tests positive, or a resident or staff tests positive, then that's a COVID-19 outbreak and there can't be any visitation until the outbreak is over. But when you're not in an outbreak, visitation is permitted if you follow these precautions. So let's talk through what those precautions are. Slide, please. Okay, so first of all, outdoor visitation remains safer than indoor visitation. To the extent that visits can be done outdoors, we strongly recommend they do so. Second, only one resident should have visitors at a time to prevent crowding in the home and to help keep track of who the visitors are and make sure they're safe. And in general, we strongly recommend you cap the number of visitors in your home to make social distancing easy. In other words, suppose I'm a family member who's visiting my loved one who lives in a DDA group home. I don't want to have any close contact with anyone in that home who isn't my family member. And doing that probably means capping the number of visitors in your home at any given point in time, so that it's very easy for those visitors to keep a full 6 feet of distance away from any other staff or residents in that home. Now, it's important to explain the risks of visitation to visitors and to residents and residents' guardians, because visitation inside a group home is not without risk. It's a healthcare setting, so people should be notified that there is some risk associated with this. Okay, screen visitors for symptoms and recent COVID-19 exposure prior to arrival, the same that you do with your staff each day. In other words, before visitors come in the home, they have to be asked, do you have a cough? Do you have a fever? Have you had any body aches, chills, muscle aches, loss of taste and smell, shortness of breath, etc.? The usual list that you're screening for. Have you had COVID-19? Have you recently been exposed to anybody with COVID-19? Anybody who has a symptom or who has been recently exposed to COVID-19 should not be visiting. So we have to keep doing those screenings for visitors. Visitors must wear a face covering. So visitors should be wearing a face covering while they're in the home. The face covering requirement for Maryland remains in place. Residents should wear a face covering if tolerated. Now, during the visit, especially during indoor visits, 6 feet of physical distance between the resident and the visitor remains the safest approach, but fully vaccinated residents may choose to have close contact, including touch with the visitor, while wearing a face cover. So those are some best practices for visitation. As you start re-allowing indoor visitation in your homes. Again, outdoor visitation remains safer than indoor visitation. Residents can also leave your group homes and visit their families. If you're going to allow families to do indoor visitation in the group homes, these are the best practices that should be followed to keep those visits safe. Slide, please. So just to quickly touch on other guidelines that are not changing. So 1 case of COVID-19 in a resident or staff of a home is an outbreak. If anybody in your home actually tests positive for COVID-19, that's still an outbreak, and all the precautions that we have in place right now still apply. All the residents should quarantine, all residents and staff should be tested, all staff working in that home should stop serving other homes and be restricted to working in that. So nothing's changed once somebody actually tests positive for COVID-19. Then we're back in crisis mode. No change to PPE recommendations for staff. Okay, and Jamie is going to walk through in just a moment PPE recommendations for staff, but there's no change in our recommendation for staff using PPE, and no change to our recommendation that residents can wear face coverings if they can tolerate them. Face coverings, personal protective equipment remain essential tools for controlling the spread of COVID-19, even as people are vaccinated. And finally, no change. There's no change to the advisory not to travel, but this is a recommendation. There's no quarantine currently required following travel in Maryland. So there's no quarantine requirement, but we're generally continue to advise against. Slide, please. Okay, and that's the reference to the CDC guidance that everything I said is based on. We're also going to put out written state of Maryland guidance in a day or two. We're just getting that cleared and finalized, but it will be consistent with what I said here. Slide, please. Okay. Jamie, I'm going to turn it over to you. Thank you.
Thanks, Dr. Fader, and thank you all so much for having me today. We'll dive into a little bit. I think it's been a while, right, since you've had a PPE donning and doffing refresher. So I hope that this will be helpful. I'm going to move through these slides very quickly. I know you have a copy of them to refer back to. Thank you. So we'll talk about a few of the infection control basics. We can't talk about PPE without talking about the most effective way we can prevent the spread of infection. And then we'll also go through the what, why, when, and how of safely using personal protective equipment. And if there's time at the end, happy to answer a few questions. Next slide, please. Thanks. So just a reminder, the basics are so essential. Hand hygiene means either washing your hands with soap and water or using alcohol-based hand sanitizer. And many people are surprised to learn that, especially in healthcare settings, unless hands are visibly soiled, hand sanitizer is actually preferred over soap and water in most situations. And that's because it's easier to access and therefore it's easier to do. You don't need to stop what you're doing and walk to try to find a sink with running water and fully stocked paper towels and soap. Hand sanitizer is everywhere and it's easy to reach for anytime you may have touched something that's contaminated. Next slide, please. We're not going to go through all of these pictures, but take a quick scan through from left to right as you go down the line here. And if any of these pictures do not match your current hand sanitizer use practice, feel free to refer back to these slides here and practice some of these techniques. They're designed to help you catch some of those frequently missed spots where germs may live and proliferate, such as between the fingers and thumbs, which are often missed. And it shows you a good technique there in number 7 on how you can help avoid germs from accumulating underneath your fingernails as well. And you can do that all in about 20 seconds. Next slide, please. And when the hands are visibly soiled, or for example, you help to take care of, or you visit someone who has a GI illness like diarrhea or vomiting, you're going to want to use soap and water. The basics are here: wet, lather, scrub, rinse, and dry. We don't want to wash with soap and water too many times in a day because it may dry out your hands. So again, unless they're visibly soiled, go ahead and use alcohol-based hand sanitizer as a default and soap and water as necessary. Next slide, please. So when should we use it? Hand sanitizer, again, when you enter the facility, before and after direct contact with a resident or something in their environment, which could be contaminated. And this is one I think we forget about a lot, but is really important. I'll mention it a few times. Before and after adjusting or removing PPE. PPE should always be considered contaminated, especially the front. And so every time we touch it or adjust it, we should try to build that muscle memory of reaching for the hand sanitizer afterwards. Soap and water hand hygiene, I mentioned already, should be used when hands are soiled, after using the restroom, before eating, and after carrying someone with diarrhea or vomiting. Next slide, please. Cleaning and disinfection, these are the basics. Please wipe off your eye protection if it's worn. Each time it's removed from the face, it should be cleaned and disinfected. Wipes typically do both, but you can wash it with soap and water first and then disinfect it if you prefer. Also, make sure that things are cleaned and disinfected before you leave the facility, like your pens or clipboards or any other supplies that you may take with you. Next slide, please. Social distancing is a buzzword we're all familiar with in the epidemiology and infectious disease world, but I'm really happy that's now part of the common vernacular for many of us, but it is still essential. It is still a really important tool to help us prevent the spread of respiratory disease. Next slide, please. Masking, as Dr. Fader mentioned, this mask mandate is still in place here in Maryland. It does protect you as well as everybody around you, and it is the expectation that everyone here in the state will continue to wear face coverings as tolerated within 6 feet of others. The situations and the scenarios here in bold are things that we see very often. I'm going to different facilities throughout the state. Please, it's important to remember not to remove your mask to take pictures, not to remove your mask to be more easily heard, or while speaking on the phone. Those are all situations we see, unfortunately, quite frequently among staff. So just gentle reminders there. Fight the urge to do those, please, and keep protecting those around you. Next slide, please. And masks, of course, should always cover both your nose and your mouth to be fully effective. Next slide, please. Staying home when sick is essential, and I think this gets missed. And now that more and more people, fortunately, are being vaccinated, it's very easy, I think, for some folks to kind of discount some of those minor symptoms, cold-like symptoms. They say, well, I can't be COVID, I had my vaccine, and that is not true. If you have any symptoms of COVID-19, no matter how mild, or you have someone at home who is ill, please notify your supervisor, stay home, and follow your occupational health guidelines before returning to work. As you are screened upon entry to any facilities or public spaces, please answer those screening questions honestly and completely, and please don't discount any of those mild symptoms or automatically attribute them to some other process like seasonal allergies, for example. Next slide, please. Covering coughs and sneezes is a really effective tool we don't talk about enough, I don't think. Covering your mouth and nose with a tissue when you sneeze, or if you don't have one handy, go ahead and sneeze or cough into your elbow. That will help keep your hands clean and help you avoid touching other surfaces after catching some of your respiratory secretions. And of course, wash your hands afterwards, please. Next slide. All right, so what is PPE? We've heard this term many, many times. There's your OSHA definition there. Specialized clothing or equipment worn by an employee for protection against infectious materials. And next slide, please. Why do we want to use PPE? Click again, please. There we go. That's the reason why. Certainly this was taken pre-COVID. This is why we encourage masking, why we encourage eye protection, because we know that not all individuals are capable or are able to or will tolerate wearing a mask, which is source control. And if that person then sneezes or coughs like this, and we're not protecting all of our mucous membranes with a mask and or eye protection, we're going to make that face. Next slide, please. So when do we use PPE? I'm highlighting this and you say, what is this doing in this presentation? Well, listen, these are all different types of PPE, right? The firefighter's wearing a flame retardant suit and a respirator. The chemical engineer at the top there is wearing a chemical rated jumpsuit, as well as a respirator. And a construction worker down at the bottom, right, might need eye, ear, and hard hat protection. And that's because they face those specific hazards on their job. And we wouldn't trade that PPE between those different disciplines, right? And so more PPE or specialized PPE is not always better. We want to choose the PPE that is most appropriate for the hazard we expect to face in our workplace. Next slide, please. So what do we use for COVID-19? We all want to wear a mask. We want to wear eye protection whenever we're within 6 feet of someone who potentially is infectious. And I would argue that in this picture, that mask is not properly fitting, and we're going to talk about that in a minute. We also would expect to wear gowns or gloves only during direct contact activities, and we'll talk about that more in a moment too. Next slide, please. So here's just a quick difference here between procedure or surgical masks that you see here on the left, respirators on the right. Surgical masks protect us from infection spread by respiratory droplets and sneezes and coughs, and it also protects others from us, from our own respiratory droplets when we speak, when we breathe, sneeze, or cough. Respirators, on the other hand, are specialized equipment. They are meant to be worn by healthcare providers who are doing very close contact activities and specialized treatments where those respiratory droplets, normally quite large, heavy droplets that fall to the floor within 3 to 6 feet, which is where the social distancing guidance comes from, and before falling to the floor, where they could actually be converted into smaller particles that may remain suspended into the air for a longer period of time. And in those cases, respirators are required, and they require special testing and training to be worn appropriately. Next slide, please. Eye protection, there are lots of different kinds out there. They're all okay as long as they have something that wraps around to protect the sides of the eyes as well. Again, something to help protect your mucous membranes from during close contact when splashes or sprays are expected, or coughs or sneezes. Next slide, please. Gowns. So gowns are meant to prevent the spread of diseases that are spread by direct contact, by touching, right? So protects your clothes and protects the skin of the caregiver while they're providing that direct care. They are not meant to be what I call the superhero cape, where you put it on at the door and you just think you're wearing superhero armor for the rest of the day. They are specialized equipment, and they are meant to be put on when you expect prolonged direct contact with splash or sprays or some other body secretions, or prolonged direct care is required. Then they should be removed after that care is performed, hands washed, and then you move on to the next task. They're not meant to be worn throughout a facility. Next slide, please. Gloves, same thing. I'm really happy that I've seen fewer of these in grocery stores, for example, than I did early on in the pandemic. It made me cringe. Gloves also only worn for times where you may come in contact with blood, body fluids, or secretions. They are not a replacement for good hand hygiene. So what we definitely don't want to see is a pair of gloves being put on at the door and then worn by that same staff member for hours at a time, all throughout the facility, touching multiple surfaces, touching potentially, for contact with multiple residents. It actually maybe is doing more harm than good, because you increase your risk of cross-contamination. So wearing gloves and then touching multiple objects can actually spread infection, not prevent it. So wear them when they are needed, then properly discard them and wash your hands. And we'll go through that on the next slide, please. One more. Thank you. So there is a correct order for putting on PPE and then taking it off. So putting on PPE, everybody, of course, already in public spaces should be wearing a mask. That goes on first, followed by your eye protection. Then you would put on a gown if it was needed, and gloves last. And then on the next slide, please. Removing your PPE happens in that exact opposite order. So you remove the PPE that's considered most contaminated first. So your gloves have touched multiple surfaces. Those are most contaminated. Gloves come off first. The second thing that comes off is your gown, because the front of that gown is considered highly contaminated, followed by your eye protection and your mask when it's safe to remove, when you're no longer within 6 feet of others. Next slide, please. So well-fitting masks are really essential. CDC's put out some guidance on this. It's up a link in the next few slides. Making sure masks fit snugly against the face and have multiple layers are going to be your best bet. Next slide, please. They've also come up with some other suggestions on how to help your mask that you already own, the masks you already have, how to help them fit better. So one of those solutions is to choose a mask with a nose wire, as you can see here. Next slide, please. I've never seen one of these in person yet, but I'm told they exist. A mask fitter or brace that you could wear over a mask to help prevent air from leaking around the edges. The next slide, please. Check for gaps when you put on the mask by cupping your hands around the edges of the mask, just to make sure that there aren't, very extensive leaks of air as you breathe in and out around these edges. And you may replace it or cover it with a different mask if you do feel that there's not a good fit. Next slide, please. And this little recommendation that's buried among all of these other suggestions, right, for helping your mask fit better, sort of exploded into this misconception that CDC is now requiring double masking. Well, the source of that rumor really came here among some other interviews that I'm sure you're familiar with on mainstream media. But the idea here was to help folks who tried those other strategies I just mentioned, but they still have a medical mask that doesn't fit properly. And so the recommendation then, based on a mannequin study, was you can add a cloth mask on top of that to help kind of seal the edges to prevent air leakage and protect the wearer a little bit better. Here at MDH, we do not recommend the use of cloth face coverings in healthcare facilities, so just keep that in mind. But it is a tool you could use out in the community if you'd like. Next slide, please. And another strategy is you may consider knotting and tucking ear loops. I know I have to do this. Those of us with smaller faces, there is a gap on our surgical masks around the cheeks. So if you need to fold the edges in slightly or tie knots around the ear loops before you put it on, that may help conform to the face a little bit better as well. Next slide, please. Things you don't want to do, according to CDC, you don't want to wear two disposable masks on top of each other. It's not going to help the fit of the mask underneath it, and you are potentially going to end up adjusting it more often with no additional protection. Next slide, please. The other thing you don't want to do, according to CDC, is wear any mask over an KN95. And those are the ones that look like they have a crease down the middle. Many of those are commercially available now, but you don't want to wear any other masks on top of a KN95. Next slide, please. So putting on your face masks, again, we talked about just make sure it fits properly, it's tied appropriately. The key is you're not going to want to touch it. You don't want to have to remove it very often. So make sure that it fits comfortably and that there's no twisting in any of the ties that would cause discomfort. Next slide, please. Same with face shields. Just make sure that they're on comfortably so that you won't be tempted to adjust it multiple times. They can increase your risk of contamination. Next, please. Gowns, pretty self-explanatory. Just do, please, if you need to wear one, make sure that they are tied at the top and bottom. Next slide, please. Gloves, make sure you find a glove that is a size that fits you. They may actually increase your risk of contamination if they're too large, for example. And do cover the cuff of the gown if that's possible with the glove. Next slide. Like I've said earlier, try not to touch your PPE. It's very hard. Studies show we're all human. We may touch it up to 12 times an hour without even being aware of that behavior. So it's a fun game I like to play sometimes in healthcare facilities where I have somebody stand at the front of the room during a change of shift huddle, for example, and keep a clipboard and make a little hash mark each time they see someone in the group adjust their mask, and then present that number at the end. And it's usually quite a large number. We all do it and we don't realize it. So try to avoid touching it. And if you do touch it, go ahead and use hand sanitizer afterwards. Next slide, please. Quick reference here might help you, the technique to safely remove gloves. Common mistake I see is that somebody takes their gloved hand and they reach under their glove on their non-dominant hand to remove it. You just contaminated the skin underneath, right? So go ahead and pinch the outside of the glove to remove the first one, and you can go ahead and use your clean hand to remove that second glove. Next slide, please. Oh, and don't forget hand hygiene. Gloves come off, hands get washed. Removing isolation gowns can be tricky too because they are considered highly contaminated, especially in the front. So as you unfasten the top ties of an isolation gown, go ahead and use those ties before you let go of them. Use those ties to start pulling it down, down and out into in front of you, and bend slightly forward so that you can kind of roll the gown into a ball and throw it away without having it swing back and contaminate your clothes or anything else in the surrounding area. And discard that immediately after use. Next slide, please. Removing your goggles or face shield, try to grab, again, the least contaminated part, which is usually around the ear. So whether you're wearing goggles or a face shield, go ahead and try to remove it from as close to your ear as possible rather than touching any of the front surfaces, which may be more contaminated, and then remove that up and out. Next slide. Masks, again, make sure you're somewhere safe before you remove it, not within 6 feet of others. Please don't litter, make sure it goes into the garbage can. And as you remove that last piece of PPE, please don't forget to wash your hands. Next slide, please. So key takeaways, wearing a well-fitting mask plus eye protection when you're going to be within 6 feet of someone, especially if that person can't wear a mask, staying home when you're sick, keeping your distance, and washing your hands are truly your best defenses against acquiring or spreading COVID-19. And removing your soiled PPE safely and washing hands when you're done are really essential parts of infection prevention. So thank you all for all you do, and thank you for having us today.
Thank you. I guess, Rhonda, do we have time for questions?
Bernie, I'm going to defer to you. There are a number of questions, and we will definitely be sharing these with Dr. Fetter and Jamie to get some answers to your questions, and we can share that with you. I know we are at 2 o'clock. So Bernie, would you like us to try to go through a few questions or do the
well,
follow-up?
let me just say this. I'm concerned with, I don't know what Dr. Fetter or Jamie's time constraints are.
I can answer questions for a couple of minutes.
Okay, all right. So why don't we say 5 minutes or whatever, Rhonda, for the questions for Dr. Fetter and Jamie, if they both can stay.
Okay, great.
My pleasure.
Thank you.
So Dr. Fetter, several questions. If staff are fully vaccinated and are exposed, staff cannot return to work until a negative test results are received, ?
Yeah, that's good. Yeah, that's a good question, actually. I don't know what to think about that. So that's a good idea unless you have a staffing shortage, I guess is what I'll say. So your staff don't need to do a full 2-week quarantine if they have a high-risk exposure to COVID-19. They should be tested. While they're waiting for those test results, it's a good idea for them to not work. I agree with that. Yeah, they should wait until they have that negative test result. But, you know, we continue to permit them to work even following that exposure if necessary to prevent a staffing crisis in that home. So, you know, that exception still exists. That if it's needed to prevent a staffing crisis, you know, staff can continue to work even following exposure if they would otherwise need to be quarantined. That's right. But the best way to do it is if staff have a high risk exposure to COVID-19, they should be tested, and it's best for them to wait to return to work until after they have their negative test result.
The next question is, what if the visit outside the home or with fully vaccinated family and friends in small groups? Do they still have to be tested and quarantined until results are obtained?
Yes. That's yes. So that's right, until they have a negative test result when they come back, right? So the one way you could do that is they can be tested during the 48 hours before they come back to the home, right? In other words, if they go get tested while they're outside the home, 48 hours before they come back and they get their negative result back, then they're good to go when they come back. Otherwise, they should be tested as soon as they come back, and then they're good to go when they get the negative result. This is for fully vaccinated residents, by the way, fully vaccinated residents. There's no change to our quarantine recommendation for residents who are not fully vaccinated. So yes, it doesn't depend on who they're visiting. It doesn't depend on who they are visiting. We still recommend testing. And I think, you know, just to give a little bit of logic about what's going on here, the idea here is that vaccines make us a lot safer. And so we should remove the things that are, you know, now that our lives are a lot safer once we're fully vaccinated, when somebody's fully vaccinated, we want them to have a much greater degree of normalcy in their lives. But those activities still involve risk. And the way we protect against that remaining risk is by continuing to use testing and personal protective equipment. Because it's, you know, those sort of lower burden activities like testing and personal protective equipment are much better things to keep doing as we roll back some of these other restrictions and allow people to visit their families and see loved ones again. So that's a long answer to the question, but the short answer is yes, testing is going to continue to be recommended.
Great. There are some concerns about some of the information, and I'm just going to read one of the comments. It says, really concerned with everything the governor has relaxed in the state, and yet this is even more restrictive than we currently have. So mom can visit in the home, and residents do not have to test or quarantine. But if they go to mom's home, they must be vaccinated and quarantined. No restaurants, even with the governor's lifting restrictions, the nursing homes and assisted living facilities are not currently even implementing these stringent guidelines.
Sure. So let me respond to that, because I think it's actually because there's three separate points in there. So the first is nursing homes and assisted livings are now allowing visitation with guidelines, and the guidelines for visitation that we've presented here are similar to the guidelines that exist for nursing home and assisted living programs for how to do safe visitation. The second is that the goal here is to make it much easier for folks to visit their families. In other words, before we were recommending a 2-week quarantine for everybody to visit their families. Now if you're fully vaccinated, you don't have to do that. You just have to be tested. And usually those test results come back really pretty quickly now. And so really the idea is to make it much easier for people to leave the homes and visit their families as soon as they're fully vaccinated. Now, as far as what people do when they're with their families, we can't control that. Restaurants are open, as you said, in the state of Maryland, and we can't restrict people's activities outside their homes. For your residents, because they are high risk, we continue to recommend they adhere to strict social distancing guidelines while they're outside of their homes, right? So what that means is they can go visit their loved ones, but we advise they avoid anywhere that would be, confined spaces, require them to come into close contact with people outside their household, or, interact indoors with people who are unmasked, who are not the people who they are visiting, right? So restaurants are just one example of something that falls in that last bucket, that it's just generally safer for the residents of your group homes to avoid while they're outside their homes. So again, this is a relaxing of the precautions, right? Because there's less restrictions for residents who are visiting their families. And, now people can have visitation in their group homes with similar guidance to what's in place with nursing and assisted living programs. So we hope this will help facilitate the visitation that everybody has been longing for, but at the same time, we want to continue to urge caution as we roll this out.
Great. And Dr. Feder, as you know, our service delivery system includes supports at day programs, and
Sure.
And so we're getting some questions about that. Can you share your thoughts about our day programs who are thinking about reopening, and in terms of whether people are vaccinated, whether daily testing is needed, and those type of items?
Okay, that's a fantastic question, and it's not it's not addressed in the guidance that I just put out, and maybe it's something that we need to circle back and put on paper. So I'm really glad to the people who raised that. I think in general what I'll say is, and this is going to be my general themes throughout, is that it's safer to be vaccinated than unvaccinated. So we want to strongly encourage people to be vaccinated. And as you reopen your day programs, if you choose to do so, it's best to keep in place masking. Masking is really, really important for continuing to keep people safe. Testing never hurts. In other words, if your question is, should we test in X situation? Well, right now we don't have a testing requirement in place for day programs, I don't think, but I'm never going to recommend against testing. In other words, as you continue to permit more activities, it's a great idea to continue to include testing in those activities, because then whatever it is that you're permitting is just a little bit safer, because on the off chance something doesn't work, right? If somebody has COVID-19. So we're always going to continue to encourage testing, and at least for now, we are definitely continuing to recommend mask use in those settings. Now, I think what we do need to circle back to, and I don't have an answer to, is how to manage unvaccinated versus vaccinated people in day program settings. It's a great question, and in general, what I would say is a good way to think about it is that people who are vaccinated are protected, and people who are not vaccinated are, for the most part, not protected. And so, it's worth considering that we would want to use the same level of precautions for unvaccinated people that we were using for them before vaccination was available, at least for the time being. The reason because, at a certain point we may reach, and I hopefully we will soon reach a place where COVID-19 is extremely rare, right? As many people are vaccinated, we can drive the rate of cases in the community down very low. And then for the few people who are left who are unvaccinated, the world becomes safer just because COVID-19 is not out there. But right now it is out there, and it's still pretty common. And so if you're unvaccinated, other people being vaccinated just doesn't keep you that much safer.
Great, thank you so much. Bernie, I know it's 10 after. I'm just seeing if you'd like to close, or would you like me to continue answering or asking questions?
No, again, I want to be cognizant of Dr. Fetter and Jamie's time. It's almost 1:15. Usually we take all of the questions and put answers and post them. Again, I want to thank Dr. Fetter and Jamie and all of our DDA staff who presented and everybody who joined us in today's webinar. So be safe and have a great weekend, and thank you.
Thank you.